I've been doing world trade pretty much since the beginning, although there are a few people that I'm going to mention that actually started it before me. But in any event, this is an Elizabeth fire truck here because because I'm from New Jersey, and that's the Elizabeth fire truck going across on the Staten Island ferry to get to the 9/11 disaster site. And with that, I'd like to talk about the response to the 9/11 disaster site and what it is that a number of us did. And again, for those people that have been doing it for a really long time, some of the slides, we all show the same slides, but for the plenty of people who haven't been there since the inception, we'd like everybody to understand exactly what the hazard was, how we identified the exposed population, what we do to understand the health effects, surveillance program. I expect that most people who are part of the ERC will be in some way involved with surveillance programs. And surveillance is really important, whatever the kind of illness is, to understand the relationship between exposure and illness and to properly document the cause and effect relationship. I spend a lot of time thinking about treatment. We do a lot of research in this program. We do community service, and we do an awful lot of benefits for our patients, and we'll go from there. So this is partially old and partially new. That should be residents. An estimated 100,000 local workers and residents were in the area. That's an estimate. We really have no idea on that number. So far, we think we found at least 84,000 rescue workers. There's probably more, but these are the ones that we found. I said I wasn't the first person involved with this. Steve Levin was one of the first people involved, and he's no longer with us. And he was one of the first people that went out to the site as a physician to figure out what was going wrong with him. And he is one of the people that we miss. And Dr. Paul Leoy from Rutgers was one of the people who actually figured out what was in the World Trade Center dust, wrote a book on it, and also died at way too young an age, and we wish he was still here. And Jim Melius was a great occupational physician, leader, was with NIOSH, was with all the local labor unions. And so these three people were instrumental way back in the beginning for getting us together, helping us to figure out what to do, and helping us to get funding for what we actually did. Without Jim Melius, we would never have had the Zadroga Award, which has paid for a lot of what we do. So based on the original work, and this is a lot of Dr. Leoy's original work, so there was a big fire. The building fell apart. Buildings fell apart. There's all kinds of construction debris all over the place. But it turns out, you'll notice that I have chrysotile as not the top exposure, so that would be asbestos, but rather I have cement as the top exposure. People think, oh, cement's not such a big deal, but when you have more than 100,000 parts per million of it, cement is a very big deal. And these are some of the other things, wood and soot and glass and fibers. So the next slide, why is cement so bad? Cement is so bad because it has a pH of 11.5. It is so highly alkaline that basically it destroyed the mucous membranes, and people's noses, people's respiratory tracts, allowed for early injuries because of the destruction of mucous membranes, and allowed for later injuries and illnesses because of all the things that were absorbed that really shouldn't have been absorbed. So none of us want to volunteer for pH of 11.5 exposures. But ultimately, and again, Dr. Leoy's work, we couldn't really measure the gases that were there. And the gases, extremely toxic, extremely carcinogenic. Fires, the particles were suspended, then resuspended, the plume spread all over the place. And again, all the particle exposure. And for those people that are that know Manhattan really well, these are some of the landmarks in Manhattan. And for those people who don't know Manhattan really well, you can see this map. You can see the proximity to Brooklyn. You can also see the Staten Island Ferry Terminal. And if you look at the Hudson River, you can see, and the Holland Tunnel, you could see that certain areas of northern New Jersey and Staten Island and Brooklyn were all potential exposure sites, in addition to the obvious World Trade Center sites in the immediate area. So this is what the stuff looked like. And we have a lot of measurements again. See Dr. Leoy Wiesel and Panos here. And it turns out that the first 4 days were important in terms of exposure because it rained. And after the rain event, there was a little bit less exposure. But for the people who were there on the first day, you can see that the exposure was huge. And again, this is another slide about particle size and absorption. And so this is a nice slide that I borrowed from Dr. Moulin. If you're on, thank you for this slide. And it kind of tells you which parts of the structure are responsible for which health effect. So the cement, the acute irritation, as I said. Now fire retardant is in the news quite a bit lately, and IARC just made a decision about firefighters and cancer. So this fire retardant that we mentioned here is not unique to the World Trade Center fires. It is used all over the country, and finally coming up with some safer alternatives. But so there are many reasons why people get cancer. Plastics from combustion, hydrocarbons, furniture fires, again, that may or may not be unique to World Trade, except for the largesse of World Trade. So what did we do? And again, Steve Levin was one of the pioneers here. And when he went out with the original group from Mount Sinai, it became apparent that this was not something that Mount Sinai could do by itself. Not everybody who worked there, lived there, whatever, was in close proximity. Many were in New Jersey and Long Island and other parts of the city. And so a consortium developed in what we call the General Responder Program, Mount Sinai, NYU, North Shore LIJ, Stony Brook, and Rutgers. Of course, the FDNY, they were enormous, but since I'm part of the General Responder Program, that's why I put it first. There's a Survivor Center of Excellence that Joan Rybin runs downtown, the national program, which helps people all over the place. And we have identified 120,000 members that are in some kind of treatment in all the programs. As I said in an earlier slide, 67,000 general responders have been identified in the non-FDNY, 17,000 in the FDNY cohort. So what was the clinical response? So first, I'm going to speak about the initial clinical response. The initial clinical response, NIOSH, and we're grateful to NIOSH and all the original people, but you notice the numbers that I said of 84,000 people that were identified in the responder program alone. Initially, we thought we were looking at 12,000 people. And we were, our initial program, that's what we did. We looked at the people we could easily identify who they were. And we wanted to identify current physical and mental health programs to serve as baseline for future exams. This is well before we were treating people, and of course to aggregate data. And having said that, in 2002, we had a meeting in Mount Sinai with the original investigators, and we sat there and we figured out the best ways to standardize things. And I'm going to be telling you that in the next few slides, what we did. This even included having an ear, nose, and throat doctor looking at Dr. Moline's nose on a big wide screen to make sure we were all reporting the findings in the same way. So in order to do this right, we need to have an accurate registry. And again, I'm speaking of responders because that's what I do. We want to have knowledge of the components and the route of exposure, baseline medical exams, and thanks to the folks at NIOSH, adequate time and resources to do education with the patients and hopefully change some behaviors in order to decrease the exposure. It's a fine line with surveillance and treatment because you want to make sure that our patients feel like they're treated, but we want to collect the data in a correct way that it's meaningful so that we can tell what happened from our exposures. So these two slides, this one and the previous one, I borrowed from Dr. Reisman in NIOSH about the balance between collecting data and actually treating people. And this is really important because of the way we've done this. We've been able to identify emerging conditions, and I'll be telling you about that. Enabling good quality research at the same time as we're able to actually treat patients. So what did we do? We came up with various questionnaires which were interviewer administered. And so the interviewer administered questionnaires, and I'll explain what they are on the next slide, are administered as close as we can to the same way in every program, administered by well-educated registered nurses in order to take medical information down in a standard way. Then the physician administered examination. And as I said, we do the best we can to have as close to the same examination in all of the places. And an exposure assessment. Our spirometries are ostensibly done the same way in all the places: chest X-ray, blood work, and mental health screening and evaluation. So we did the best we could to have standardized questionnaires to do this that have been well tested, well used, and well scaled. My favorite one, since this whole program is based on cough and mucus, this is the SNOT 20, which is a way of asking about how much mucus people have and how much it bothers them. But basically, these are all standardized, well-tested questionnaires that have been used in various places. And the same thing with mental health. Cage, many of you are familiar with that alcohol questionnaire, but you see we have PTSD, general health, disability, et cetera here. And We have people who score in that get automatically referred for treatment, and then we have obtained all the rest of the information and we put it in our database program. So this is our physical. We all use the same spirometer, so we can make statements about what happened on people's breathing tests based upon not just the data in New Jersey and not just the data in New York and wherever. It's all downloaded, and we can look at all those 67,000 people. So this is one of the first papers that we were able to come up with, and we and this was after 5 years, and we were able to look at what some of the most acute health effects. So remember what I told you about the 12,000 people. So this paper was based upon the first 9,400 people that we were able to get data on. And we found that from the original people, about half reported being engulfed in the dust clouds. And there was a range of exposure. Not everybody was seen right after their exposure. But look at this next slide here, because this continues. 69% of the people that were at the 9/11 disaster site reported at least one respiratory symptom, and this number persisted. 55% symptomatic at the time of exam. This number persists even now. So these are acute health effects that we continue to treat, and early arrival is correlated with more health effects. So this is an FDNY slide, and they were able to take a really good picture, and they had spirometry or breathing tests before 9/11 and after 9/11, and they were able to show that everybody that was there lost 372 mLs of volume, and they never got it back. Then the two curves are parallel. And who wants to volunteer to lose any part of their lungs? And we basically were able to show this in the general responder population as well. We didn't have the before and after as well as the FDNY, but right away we were able to show this in all the programs that we had. Decreased lung function. So that was the original surveillance data. Because of our surveillance data, we were able to establish a treatment program. And first there was some philanthropic funding, but it became clear that we needed federal money to help treat our patients. We couldn't just say, you have a problem, go get it treated. Wherever we had to start treating people, we had to come up with covered conditions that our research was able to show was related to 9/11. And lo and behold, we were able to show at the 9-year mark, that we had persistent asthma, sinuses, gastroesophageal reflux, abnormal breathing test, and this is among the first 27,000 participants. So we expected the asthma and the sinus. We weren't so sure if we expected the reflux. So reflux was certainly added on as a condition. Lo and behold, we found that an awful lot of our patients had sleep apnea, and we started noticing it because we're a small clinic, that the people we were referring to our sleep clinic were not people that weighed 400 pounds, that they were just regular people. And compared to other people who go to the sleep clinic in New Jersey, the World Trade Center responders were way thinner, lower BMI, and more associated with respiratory conditions. And so we hypothesized that obstructive sleep apnea was possibly due to all this airway inflammation. We also found a good amount of mental health issues in our responder population. Interesting, at the 9-10 year mark, it was more non-law enforcement, and we can comment about that. You can either say that the law enforcement people were more prepared and more resilient, but what I want to say is that the law enforcement people maybe were less than truthful about filling out our forms while they were actually still on duty. So now, as we go on, past 10 years, later emergent disease, and we started seeing more cases of sarcoidosis than and other chronic lung illnesses. Sarcoidosis is the quote Zadroga illness. This is a beautiful FDNY slide, which shows the spark increase in the diagnosis of sarcoidosis and interstitial lung disease after 9/11 compared to before 9/11, and this was replicated in the general responder program as well. So again, late emergent disease from 9/11. But now I'm going to be spending most of the last part of my talk about cancer in 9/11 responders, because this is what we're dealing with now. In the beginning, we weren't sure. Of course, we had all these hypotheses and all these reasons why people could have cancer. And even early on, this is the FDNY, that there was an increased rate of cancer in 10 to 15 of the cancers surveyed initially. This is FDNY. Blood cancer would have a short latency, and right away you might see blood cancer, but they had baseline data, and there was already some concern about thyroid and possible prostate cancer. Similar findings in the general responder population. And we also, this is the same study, and the incident rate was slightly higher. I want to point out thyroid cancer, prostate cancer, hematopoietic and lymphoid cancer, and that has a decent SIR. We weren't sure what the soft tissue cancers meant at the original time, but we'll go from there. And then there was the registry. The World Trade Center Health Registry registered people who lived in the area, people who are not necessarily involved in programs where they were going in for medical exams. What's important here is that these cancers were elevated no matter what way we looked at them: the prostate, the thyroid, multiple myeloma. And so we had 3 different cohorts using different methodologies, and we were able to show right away that there were increases in cancer, and it didn't matter who people were, all racial groups, all ethnic groups, all sex groups, because we were able, prostate is mainly men, but of course, we were able to show that there were increases, and the prostate rate is key here, and it continues to be an issue. Head and neck cancer, that's something that we had a big case series here in New Jersey, and it wasn't something we expected to see. So again, as we go forward, as we keep increasing the dates, we continue to see elevated rates of the same cancers. And so in 2022, in the responder population, well, I'm not sure the significance of non-melanoma skin cancer. Prostate cancer, no matter what way we look at it and no matter who we look at it, it's elevated. Again, the general responder population is something like 85% men. Lymphoma is very high, kidney is very high, bladder, lung, many non-smokers, colon cancer. The survivor program, of course, breast is much higher in the survivor program than in the general responder program. Notice that colon continues to be high. And so this is an overall look at the number of members with what we call certified conditions. And what I said, something like 84,000 members in this group. And looking at these numbers, an awful lot of people have a certified condition. See, these aren't mutually exclusive. These are the number of people that have each one of these conditions. So thinking about people who can have more than one. Challenges as we go forward, improving the quality of life of our patients. We do all this cancer detection. We do the best that we can to make shared decision-making, even in doing the tests for cancer detection. Not everybody wants to be treated. We try to be sensitive to that. We try to be sensitive to the side effects of treatment. We have issues of pain control, pain management, metastatic disease, mental health issues concerning the diseases, pain, osteoporosis, and as I said, secondary cancers, mental health effects. We're looking at new conditions. There are already a few studies. There's a study from FDNY about connective tissue. Maybe it could be elevated. There's a study about cardiac from the general responder population. Maybe it could be elevated. There's concern about certain kidney problems. We're concerned about neurologic and cognitive issues. These are the reasons for surveillance, because we don't have enough information to know about any of these conditions, but we certainly have a lot of worried patients that ask us about these conditions. So finally, I will say that I am really grateful that I get to do something that I know how to do. Patients who came and ran towards the disaster while the rest of us were running away from it. I am most grateful to the patients who come here for their examinations. I'm grateful for my own staff and fellow faculty members here in Rutgers, but I'm grateful for all the staff and doctors and nurses and all the healthcare workers, administrators at all the clinical sites, all the folks that NIOSH that not only fund us, but make us able to do what we want to do and spend the right amount of time, but especially Dr. Howard, who runs NIOSH and has been before Congress many times, and Dr. Dory Reisman, who's been our leader in the program. She's now an admiral in the Public Health Service, and a wonderful physician. And as I said, all of us and my family that allows me to go to work and do all these things. So I guess that